Well, thank you very much, Gorm. And I would like to start by thanking the jENS organisers on two counts. First of all, for inviting me to give this lecture, which is perhaps slightly broad, but perhaps that's a good thing at the end of a long day. But also for putting together an excellent meeting, because I've thoroughly enjoyed the last couple of days here. So thank you very much, jENS organisers, and congratulations for what's been a very interesting meeting. And I will do my best, I hope, not to spoil that reputation. So the topic I was asked to speak about was, as Gorm has said, how can we achieve closer integration between clinical practice and research? And over the course of the next few minutes, this is a broad topic, so I'm going to focus on just a few areas. But I would like to start off by asking you all to reflect on this picture, which is a very famous picture, will be known to many of you. It's entitled "The Doctor." It hangs in the Tate Gallery in London. It was painted by Luke Fields, and there is a story behind it, but it's also a picture that's been used for multiple reasons. It's been used to depict the compassion of the Doctor when he watches helplessly at a child for whom he can do nothing. It's also, curiously, been used to argue against publicly funded medicine. That's another story for another day. But it's clearly a picture that has resonance for people. And when I look at it, I like to think that it not only shows the Doctor showing compassion for his patient, but also looking quizzically and wondering why things are going wrong, why he can't, what is the mechanism of the disease that he sees before him, not only compassion for a sick child before him. And so for me, I would like to say that this could be taken to depict the coming together of the Doctor as a clinician and the Doctor as a researcher. And around about the same time, another very famous doctor was creating one of the most well-known figures in fictional history. You'll all recognize this famous silhouette of Sherlock Holmes. And Sherlock Holmes was, of course, a creation of Sir Arthur Conan Doyle, who was a physician who trained in Edinburgh. And one of his teachers was one Joseph Bell, who taught him how to observe. And it was out of the careful observation of patients that we have the wonderful series of Sherlock Holmes stories where Sherlock bedazzles everyone around him with his acuity and his insight. So the relationship between doctors and research has always been a very, very, very close one. But as Gorm alluded to in his opening comments, perhaps there are areas now where our respective roles have become slightly polarized. Perhaps we tend to work in silos. Perhaps there's a feeling that the researchers are out there and the clinicians are out there. And what I would like to do is say to you, absolutely not. We are absolutely as one, and research should be much, much more closely integrated into normal care. So consider this. This is the tools of the trade for a doctor. You take a history, you examine the patient, you come up with a differential diagnosis, you then investigate, and you then treat. And relate this to the research pathway, where you define the question very precisely. You then do a literature review, a meta-analysis. You get more information, and you bring that information together with your prior knowledge. You then formulate the hypothesis, exactly the same as formulating a differential diagnosis. And you then test the hypothesis, exactly the same as doing targeted investigations to see whether or not which of your differential diagnosis seems most likely. And then finally, you implement research findings. So these two pathways are absolutely intimately associated, and again, for me, make the case that clinical research and clinical practice are intimately related to each other. So having made those comments, I would like, for the rest of my talk, to focus on these 5 areas. I'd like to talk about recognition of the problems of non-evidence treatment. I'd like to talk about simplifying clinical research and specifically simplifying comparative effectiveness research, improving the understanding of research methods, using high-quality data to make research more efficient, and involving parents and young people. So let's take the first of these issues. We all hear, quite rightly, a lot of discussion about patient safety issues. We had a wonderful opening talk here from Captain Houting about patient safety issues. All of you, as I have heard many talks about patient safety. But I can't say I've ever heard a patient safety talk where the point has been made that lack of good research evidence is also an extremely important patient safety issue. And if you doubt what I say, let me give you some examples from the history of neonatal medicine. In the 1940s, I am told, thymic irradiation of neonates used to be practiced widely. This was believed to reduce the risk of sudden infant death. And if you read some of the discussion from that era, you will see comments made that say, by clinicians saying, well, we felt we should do this because the parents were demanding it and it's not going to do any harm. Well, how wrong could that be? So a message there that because something is demanded doesn't necessarily mean we should ignore the question of whether or not there is good evidence underpinning it. Thymic irradiation of neonates led to a 5-fold increase in cancer. Then, of course, when I was a medical student, we were still placing babies prone to sleep. Now, of course, that's fundamentally not the case. Routine separation of mothers and babies still practiced in many parts of the world, particularly in many private institutions where babies are still in serried ranks together in a nursery and the mums are somewhere else. 100% resuscitation with oxygen. Again, this used to be standard practice, but it wasn't until Ola Saugsted's and colleagues' great research that we've now changed our practice. And then most recently, antenatal steroids, long an absolute mantra for the perinatal professions, completely turned on their head because of the ACT trial, which showed that antenatal steroids in low-income countries resulted in greater neonatal mortality. So we need research, and without research evidence, we definitely place risks upon patient safety. And I'd like to draw your attention to this wonderful cover from The Lancet from a few years ago now, which says that what we should be doing is not protecting infants and children from research, but we should be protecting them through research. Very, very powerful single statement indeed. Let me move on then to simplifying clinical research, and I want to focus here on comparative effectiveness research. And by this I mean research which compares treatments which are already in use, wide use in neonatal units. And all of you could think of any number of examples of such uncertainties. We've been discussing them today in various fora. Should we give high protein intakes or low protein intakes? Should we 45 feeds? Should we not 45 feeds? Should we use CPAP? Should we use high flow? There are no end of comparative effectiveness questions that we need to evaluate. But of course, the traditional way of doing clinical trials, of doing randomized controlled trials, is very laborious, very expensive, and there are too many questions. So I think we need to think a little bit innovatively and a little bit laterally. And in order to do that, I want to go back to first principles and ask you to just recall the fundamental principles of clinical research. First of all, justice, the right of the patient to be treated fairly and to be fully informed. Second, beneficence, which is the obligation of the doctor to act in the patient's best interests. Third is non-maleficence, the obligation of the doctor to do no harm. And fourth is autonomy, the right of the patient to decide and to consent freely and without coercion. So please hold those four fundamental principles in your mind. Let's consider experimental versus comparative effectiveness research, and let's apply these four principles and see how well they fit. So when you're evaluating a new experimental treatment, there is a cardinal obligation to protect the patient against the possible harms from this new experimental treatment. So comparison is made against accepted best practice or placebo. Parents in our situation are asked if they consent for their child to be randomized, and if they decline, then the baby, receives the accepted best practice. That is the standard paradigm for experimental research. Let's consider now comparative effectiveness research, where you're evaluating treatments which are in wide use but where the evidence base is uncertain. So there's comparison of treatments in accepted use. If you would go to Dr. A, you would get this treatment, and if you would go to Dr. B, you'd get the other treatment. No one knows which is better. Parents are asked if they consent for their child to be randomized. If they decline, what do you do? Well, what happens is, of course, that the child gets what the doctor decides. Even though the doctor does not know which is the right treatment, and even though the doctor may be in equipoise and genuinely say, I do not know which is the right treatment. So the application of the fundamental principles of clinical research are not quite fitting the bill here. How could we do better? Well, consider this. Consider saying to parents, treatment A and treatment B are used by doctors every day, and we want to give your baby the best chance of receiving the best treatment, but we don't know which it is. As we don't know which is best, we want to give every baby the same equal, fair chance of receiving the unknown best treatment. And this is called randomization. And we'll then be able to find out which treatment is better. If we don't do this, well, we'll never find out what's better, and many babies will continue to receive the worst treatment. And of course, the problem is we don't know which the worst treatment is. This is the justification for such an approach, and you're absolutely free to opt out if you wish. So is this ethically valid? Well, there is justice. Yes, the patient is treated fairly. Beneficence, because the doctor is not put in an impossible position and made to choose when he or she wishes to act in the patient's best interest and randomize the patient. Non-maleficence, well, the doctor fulfills his or her obligation to do no harm. And autonomy, well, the parent is free to opt out if he or she wishes. So you may think that this is a theoretical discussion, but we have actually put it to the test in the UK, and you'll see there Chris Gale and Matthew Hyde, who were instrumental in really seeing this study delivered. We submitted the same research ethics application for a comparative effectiveness trial to, I think, 12 UK research ethics committees. The research ethics committees were notified that a trial was coming along that was going to go to all of them. They were asked whether they were happy to take part in this study, and but they weren't told which study was actually going to be the one that was submitted to multiple ethics committees. And we tested 4 principles. We tested the principle of opt-out consent for comparative effectiveness research, the use of a very short information sheet of just 1 page, explicit mention of possible inclusion benefit, and finally getting all trial data from the baby's electronic records. And this study was published in Archives a few years ago. What we found was that at the start, the ethics committees were not unanimous in their views, but Matthew and Chris went along to the ethics committees and answered their questions, and the final decision was that an electronic patient record for obtaining data was acceptable to all research ethics committees. 1 committee raised concerns about the short parent information sheet, 10 about the mention of inclusion benefit initially, and 9 about opt-out. But after they'd had a chance to discuss the rationale for this approach, the final conclusion was that 9 of the 12 research ethics committees granted a favourable opinion. And because of that, the UK Health Research Authority now accepts opt-out consent for comparative effectiveness research and accepts the mention of possible inclusion benefit, and indeed accepts the short information sheet and the electronic patient data. So we have, I think, taken a step forward here. And at this point, I want to remind you that, of course, research ethics do evolve. Once upon a time, not so long ago, in the 1980s, it was considered inappropriate for babies and children to be included in research. And it was the British Paediatric Association, the forerunner of the Royal College of Paediatrics and Child Health, that put its head above the parapet and challenged this view and said research involving children is important, it should be supported and encouraged, and research which involves a child but is of no benefit to that individual child is so-called non-therapeutic research, is not necessarily either unethical or illegal. Now, many of you in the audience will not know that in the 1980s this was a major statement because every other authority was saying that non-therapeutic research was unacceptable in children. So that was back in the 1980s, but the Royal College of Paediatrics and Child Health has since issued further updated guidance in 2000 and in 2014. And I say this to you to emphasize the point that societies do evolve in the way in which they think about these sorts of issues. And if you want some objective data, look at the revisions of the Declaration of Helsinki. You'll see you'll see that the word count for each revision has gone up and the years between each revision has gone down. So processes are continuing to evolve. The next point I want to talk about is improved understanding of research and research methods. And I say this very humbly because I have been learning about research methods my entire career, and I continue to learn about this to this day. But I would recommend to you this wonderful book called Testing Treatments by a trio of authors, including Hazel Thornton, Imogen Evans, and Ian Chalmers. It's available freely online, and it's a great read, both for the non-health professional public, but also for all of us, because it puts in language the rationale for research, and it explains how we can have a dialogue with our patients about why research is so important and is a patient safety issue. And of course there are other sources of information about better public understanding of science. But Testing Treatments is now available. I've only got whatever it is, for 10 of the translations up here, but it's been translated into pretty much every language under the sun. So I wholly recommend this to you as a very good read indeed. But recently, another very interesting randomized trial was carried out. And this was done by, this was funded by the Norwegian Public Health Council, and it was a randomized controlled trial carried out in Uganda. And it was targeting primary school children. And it was a trial to determine whether or not it was possible to teach primary school children how to judge the veracity of claims that are made about treatments. And of course, this is tremendously important, particularly now as the rise of anti-vaccination sentiment is sadly growing around the world. The public and young people need to know how can they tell what is fake news and what is good evidence. So these researchers did a fantastic trial. They carried out a randomized controlled trial to see whether or not they could successfully teach primary school children how to evaluate evidence. It was published in The Lancet a couple of years ago. I recommend this paper to you. And they've produced a host of materials. This is one of them. This is the primary school manual, which is used to teach young children about the veracity of treatments. And something else I strongly recommend. And then finally, big data. This is something I've spoken about a lot recently because I believe that we do need to think about more inventive and innovative ways to address pressing research questions. This is a schema of our National Neonatal Research Database, which brings in information on every single baby admitted to a neonatal unit in England, Wales, and Scotland, and is proving to be a very, very beneficial resource for a large number of studies, as well as policy research and health services research, and also for other aspects of care that benefit our patients, such as quality improvement. Quality improvement is another issue that is very, very popular these days, but it can be difficult to evaluate quality improvement programs with rigor. This is just one example of how our National Neonatal Research Database was used to evaluate a quality improvement program to improve preterm breastfeeding. This was one network in the east of England, which is a very large number of neonatal units in the east of England. They introduced a care bundle, a quality improvement program to improve breastfeeding, and they wanted to know whether or not this quality improvement was truly making a difference. If they'd done a simple before and after study, they would have shown that after the implementation of the care bundle, yes, breastfeeding rates went up. But how would you know that this was causally related to the implementation of the care bundle? Well, it was done by comparing the rate of change in the east of England, which is the green line here, against the rate of change in the whole of the rest of the country. And you can see that there is a difference in the slope of the lines, and this provides reasonable evidence that the east of England, because of its implementation of the care bundle, was that care bundle was actually effective, and that it wasn't just background variation that was being picked up when they made their measurements of change in breastfeeding rates over that period of time. So our vision for Europe is to gather together big data. This is my colleague, Professor Dominique Aumont, who set up a wonderful technical platform called eNewborn, which has been used to benchmark neonatal services in Europe. And she and I are coming together because we would like to use big data throughout Europe to benefit newborn healthcare through research and through policy development, audit, benchmarking, quality improvement, every reason for which you might care to use big data. So we hope that we will have the support of every country in Europe. I have to say at this point very quickly, I did not vote for Brexit, and I do not want Brexit. I hope, thank you. And I hope that we can come together as a community of neonatologists to harness big data to benefit babies throughout Europe and indeed throughout the rest of the world. I'm going to end with a word or two about strong parent engagement. This is James Webb and Susanna Tsakonidou, who are two PhD students in my group. They are supervised by Chris Gale, and they have been doing some wonderful work which has involved parents in all of the aspects of research that I've discussed. Susanna has been working on involving parents in the capture of their baby's data, so that, for example, she's asked the question, if we involve parents in quality assuring their baby's data in the electronic medical records, will it improve the quality of the data, and will it also improve the satisfaction of parents with the care that their baby is receiving? It seems an obvious thing to do because, of course, if you are a parent, you know everything about your baby. You know what treatment they had on that day. You know what they were fed. You know what ventilation they received. You know what their weight was, and so on and so forth. So what better partnership than to ask parents to help quality assure the data that's being entered for their baby? And James has been involved in establishing a core outcome set for neonatal medicine. You can see the list of core outcome measures that he's come up with here. And this was done through an international Delphi consensus group, which included parents, researchers, clinicians, and former patients. And as you run your eye down the list, you will see core outcomes, which are absolutely as you would expect them to be, but you might also see a few core outcomes which fell out and which were not ranked sufficiently highly by parents and the other users. There was also, I haven't got time to discuss this now, but there was also, as you would expect, a difference in some of the core outcomes that were selected by parents on the one hand and researchers on the other. And one surprising finding to us, but that's the great joy of research, you do find surprising findings, is that parents did not rank, curiously, did not rank breastfeeding as highly as neonatologists did. And I leave you to speculate on why that should be, and whether it is that we as clinicians are not explaining the benefits of breastfeeding sufficiently clearly. So to finish, I think that without question we should come together with closer integration between research and clinical practice. We share the same goals. Consensus-based practice or expert-based practice is a danger to patient safety. And I say this again as someone who's asked to speak and who has a title expert attached to my name, which I thoroughly reject. I think expert-based practice is a danger to patient safety. I think research is not an optional extra, but it's an essential part of everyday care, and it should be an essential component of education and training. Don't forget, some clinicians will lead research, some will deliver research, but every single clinician can and should be supportive of research. I hope that I've convinced you that we need to think about comparative effectiveness evaluations in a different way from experimental medicine studies, and we should think about it in a much more logical way that will enable us to answer some of these pressing comparative effectiveness uncertainties much more quickly than we have hitherto been able to do. We need leadership and advocacy, and hence a meeting such as jENS and the leadership of the European Society for Paediatric Research and other research societies around the world is so crucial. Routine real-world data and all of the technical opportunities to interrogate and analyze big data are now bringing new possibilities for us. But above all, I think that we will advance best of all if we advance in partnership with parents, patients, and the wider public. So thank you very much indeed, and I will end with a picture of my research group